Good evening, everyone. So I'd like to welcome Dr. Sanders with his presentation today. Dr. Sanders is an assistant professor for preventive medicine and public health and director of the DVM MPH Joint Degree Program at the University of Illinois College of Veterinary Medicine. Prior to this job, he spent 6 years in DC, where he worked 2 years at the US EPA Office of Water as an AAAS Science and Technology Fellow, and 3 years supporting the Defense Threat Reduction Agency's Cooperative Biological Engagement Program. Throughout his time, he directed the One Health Academy at one monthly gathering of multidisciplinary individuals and was an associate veterinarian at the associate wildlife veterinarian at City Wildlife. He earned his DVM from University of Wisconsin and his MPH from Yale University. He is a diplomate of the American College of Veterinary Preventive Medicine and currently serves as chair for the ACVPM's Membership and Outreach Committee. Additionally, he chairs the AVMA's Council on Public Health, and he greatly enjoys organized veterinary medicine and loves improving what the profession can get done when working together. Thank you, and over to you, Dr. Sander.
Thanks a lot, Dr. Tomasi. And I did make one edit on my bio, which is that I'm counselor on the executive board for ACVPM and no longer the chair of Membership and Outreach Committee. That is Dr. Haley Adams now. So thank you for the introduction, and I really appreciate everybody who came and attended this. Hopefully there'll be some nuggets in here that'll be insightful. Obviously, many of you have a lot of deep breadth and understanding around zoonotic disease. And so hopefully I can provide some other aspects that are important. We're certainly today going to talk about, some of the list of zoonotic diseases, but I'm not going to go into much depth on any of those diseases. Really just want to categorize them and group them, and then talk more about, what sort of perspectives do we have as veterinarians and as other health professionals have around this issue? How can we improve our messaging, and how can we try and be better advocates for, preventing or at least mitigating zoonotic disease, including things like biosecurity and partnerships within your community. So that's kind of the goal I want to aim for today. So before we jump into this, I'd love to know what people's backgrounds are, what sectors they're in. So I'm going to ask Dr. Toring to launch the first poll that asks that question. And if you can choose which of this area of veterinary medicine do you primarily work. I know some of you may work in multiple areas, but which one of these do you primarily work in? All right, how does it look, Dr. Toring? Do you want to go ahead and close it? All right. I'm not completely surprised by this by any stretch of the imagination, but it's great to see that we do have a few practitioners on here. And obviously we have a lot of folks representing government, academia, and the military uniformed services. So thanks everyone for being here. And that certainly helps me a little bit better understand the audience, which is not surprising reflection of what I thought it would be. So thanks. So what are zoonotic diseases? Well, first, I want to highlight the fact that these aren't, things that happen every so often. They happen quite frequently. And so I just want to highlight 4 items from CDC in the last year talking about this. They're all, as you'll notice, themed with Salmonella, but I still think they're pretty representative. So this first one is a Salmonella outbreak linked to small turtles. And we've seen more of these Salmonella cases pop up more recently in the last few years as more people are getting hold of smaller shelled turtles, under 4 inches, even though they're still banned for sale. And so this is an ongoing concern that we have to deal with. And how are people getting access to these, and what sort of concerns do we have with that? And then we have Salmonella infections linked to pet bearded dragons. This investigation closed last year, but still highlights the fact that, we think of Salmonella. I know my students at University of Illinois Vet School think a lot about turtles, and turtles are hardly always the culprit. There's lots of other species that are at risk here as well. And then, of course, we're dealing with bigger concerns around outbreaks of diseases linked to backyard poultry, Salmonella being one of them. And this is data from last July. But you can see, quite a few recorded cases spanning almost all of the states. And this is becoming a bigger concern. A lot of people are taking the backyard poultry and not always. And then more recently, we've had a Salmonella outbreak linked to wild songbirds, particularly passerines, and particularly linked to backyard bird feeders. And I do work right now at the Wildlife Medical Clinic here at University of Illinois, and have done work, as mentioned in my bio, in DC at a wildlife center. And this is always an ongoing concern about, what sort of diseases are we potentially spreading amongst the wildlife we're trying to rehabilitate or bring back from. And so there's definitely risks out there. And although this is a theme of salmonella in this particular examples, there's lots of other places where we could have concerns along this. And so we'll talk about some of that. So we have to have a definition about zoonotic disease in here, although I'm hopeful most of you know this definition, but it's a disease that spreads from animals to humans. And on the human animal side, we do have cases where we have things that spread in the opposite direction, COVID-19 being one of those examples. Reverse zoonosis or humanosis or anthropognosis are also terms we can use for that as well. And these are just highlighting some of the top diseases of concern around zoonotic risk. And we'll talk more about some of the other diseases along this list as well. But you can see it spans a wide variety of host species that potentially have risk to people. And most of these diseases listed here are, we're talking about risk from domestic species, but certainly wildlife plays a role too. Everyone likely knows these statistics, but I'm still going to throw these figures up, which is that over 60% of known human pathogens originate in animals, and over 75% of emerging human diseases are zoonotic. And there are greater than 50 zoonotic diseases in the US that we're concerned about, or at least that CDC is concerned about. And you can certainly see more of that here on their Healthy Pets website, which I think is a great spot to go to for a lot of our domestic and especially companion animal concerns. And then this graphic up here is from Governmental Accountability Office, and highlighting some of these diseases that potentially come from wildlife or from livestock. And then, there's plenty of them that fall right in this wonderful nexus in the middle here. And so this gets back to the concern about One Health and how do we try and address these. And certainly we're not going to delve into all the permutations of how we could try and address this interface today, but this is just one of those aspects that I wanted to certainly highlight here. So let's talk a little bit about zoonosis by species group. So we'll walk through the laundry list a little bit. Again, not going to dive into depth about, pathologic mechanisms here or clinical signs, but I want to at least highlight what diseases we're concerned about. And so I've decided to group these by species group. So we have a list of diseases that'll be by all primary species. And by that, I mean our typical dog, cat, cow, horse sort of things. Livestock specific diseases that we get more concerned about there coming from livestock. Avian diseases, companion animal, dog and cat primarily. Equine, and then others are the exotics, zoo companion animals, that sort of thing. And this graphic here can be applied to any disease, really, any infectious disease, not just zoonotic disease, about routes of transmission. And so there's nothing surprising here. This is put up by the London School of Hygiene and Tropical Medicine, but this is, again, similar to all other infectious diseases for the most part, as far as possible ways for spread. So for all of our primary species, it spans the spectrum from bacteria to fungi, with dermatophytosis up here, to our ectoparasites, to viruses up here as well. And again, not all of these are exclusive to our primary species. I try to highlight some of the other spots where these are concerned: Ehrlichia and Anaplasma, deer and rodents, spilling over in horses as well. Tularemia, obviously, I think most people think of rabbits as the first culprit there, but we've had one case in the past couple months here at University of Illinois in a cat of tularemia. So, these are diseases that aren't necessarily limited to our typical domestic species, but I want to at least highlight some of these here. GPs up here are guinea pigs, for those of you not familiar with that vernacular. And so, I think this is important to keep these on our list. And although, there's obviously diseases that are out there that are more common than many of the zoonotic ones, these should always be on differential lists and be on our radar. For livestock, we have obviously talking about anthrax. We have a concern about chlamydiosis, but certainly that goes over into cats as well. We have crypto, obviously, and erysipelathrix, which also affects birds and can affect fish and crustaceans. Tuberculosis and vesicular stomatitis, and yersiniosis, right? So there's lots of a variety of diseases here. And certainly this isn't an all-inclusive list, but I, again, wanted to provide a couple of general groupings. The birds, I always tell my students and others that, the farther we get away from our order, we get out of mammals and get into avian, the harder it is to transmit disease, right, between that group and us. And so the list gets a little bit smaller. And certainly we had a few in the 2 slides ago that potentially affect birds as well. But our list is smaller, and certainly we think about hypathic avian influenza as a potential concern, cryptococcosis, influenza A, mycobacterium, psittacosis, and West Nile. In our companion animal section here, these are kind of some of the big ones here. Capnocytophagia, obviously, is one we're concerned about with bite wounds, particularly from dogs. But obviously, there's a lot of intestinal parasites that we get concerned about spilling over into people, from tapeworm and echinococcus to larval to roundworms and hookworms. And then we get concerned about some of these other diseases too, particularly vector-borne diseases like Rocky Mountain spotted fever and Lyme disease, as well as some of the other parasites too that spill over. And so we talk to a lot about in small animal practice. On the horse side here, again, we've had plenty that have been include horses in previous slides, but specifically we get concerned about equine encephalomyelitis infections, EEE and WEE and BEE, and then Rhodococcus equi as well. And then our last potpourri bucket here of others and exotics, I think this kind of rounds out a bunch that have, there's way more than just on this list, but these are some of the ones that have, generally hit headlines or we're often concerned about, either because they have high mortality rate if they get into people, or they've had significant outbreaks in the past, and so they're heightened awareness. And so Balis ascaris is one we talk about all the time in wildlife clinic here at Illinois. Again, this is the roundworm of raccoons. They're the definitive host, but it can spill over to people, and just like a lot of other roundworms, they get into the wrong host, then they get to be a bit aberrant and have some interesting migrations. And oftentimes this goes into the neurologic system or into the eye. And so that's what this image is here up on the right. Upper right is a child in a sandbox. I have a 2.5-year-old right now, and we will not be putting a sandbox in our backyard, not only because of raccoons and loving to use it as a latrine, but also all the feral cats that also love to use it as a litter box. But you make your own life choices. I'm not putting any judgment on anybody. And so we have very few human cases of Balis ascaris that have actually spilled over. I can probably count about 20 in the last 2 or 3 decades that have been documented to be Balis ascaris. But if it does spill over, there's really minimal treatment that we can do in people, and oftentimes can be fatal. We get concerned obviously about hantavirus diseases, particularly in the southwestern part of this country. Herpes B is a big concern in our laboratory animal group of folks, working with old world primates, particularly macaques, and the concern about herpes B infection there. Histoplasmosis in bats and birds. Lymphocytic choriomeningitis is a concern, particularly in our smaller rodents, but it's pretty rare that it actually spills over and causes an issue, although we have certainly documented cases of that happening. Monkeypox, which is what the map on the bottom right is referring to. Most of you hopefully remember the 2003 outbreak that happened here in the US, centered around Gambian giant pouch rat being mixed in a similar distribution facility with prairie dogs, and those prairie dogs then being sold at various locations around the Midwest, getting sick and being a great vector of transmitting this disease to people. And unfortunately, the lesions from monkeypox look awfully similar in many cases to smallpox, which is a major concern, right? Mycobacterium marinum, which we have cases in fish spilling over on rare occasions. Plague is certainly a concern, hasn't gone away. We still have plague cases every year. And then rat pipe fever is another one to be aware of. Right, so we've gone through the distribution list here of what all these diseases are. That wasn't the focus of this talk, right? But we wanted to at least put that out there and have that that awareness there, if you're not already aware of those laundry list of diseases. I really want to talk more about drivers and perceptions of zoonotic disease, and then how are we going to try and mitigate this or prevent this moving forward. So I often lead with this, talking about zoonotic disease, and that, in 2008, there's a great study that looked at the number of adults and adolescents who had HIV, greater than 1.1 million individuals in 2008, and 250,000 folks haven't been diagnosed with HIV or AIDS. And 50% of the people with an HIV infection have been documented to have pets. How many of those have actually been consulted about, the risks that go on with that, about being immunocompromised and having a pet in your house? And so we don't want to limit people from having pets. There's lots of great benefits there, but how do we actually message that? And I think that's where the gaps really occur. A survey was done in 2012 out of Tennessee, looking at how well physicians and veterinarians can correctly identify pathogens of various concern to people with HIV infection. And sadly, 25% of veterinarians and 33% of physicians were able to correctly able to identify, but a majority weren't, right? And so that's a big concern, that neither health professional that should know something about zoonotic disease can actually effectively consult an HIV patient if they had questions. Veterinarians, typically discuss, especially in a small animal environment, parasitism, dermatophytosis, rabies, lepto, toxo, and the risk of feeding raw food diets and foodborne infections from that route. And that's great. Certainly, those aren't bad topics to cover when talking to clients, but they certainly aren't all inclusive. And then studies have looked at how much client education materials on zoonotic disease are available in clinics, particularly small animal clinics, but in both large animal and small animal. And only just over half of veterinarians actually have those materials readily available. And that seems like a big gap and a pretty easy low bar that we can check off to improve on this. And so I think that's important to keep in mind. A study also came out in 2015 by Stahl in the Canadian Medical Association Journal that looked at those households with somebody who recently had a cancer diagnosis and found that 70% of households obtaining new pet after a cancer diagnosis acquired a high-risk pet. So a pet that potentially has a bigger risk associated with spreading zoonotic disease to an individual. So I boiled it down kind of to these 3 points here, right, for zoonotic disease and why we have kind of a gap between human and veterinary medicine. Human medicine doesn't generally dive deeply into zoonotic diseases. In veterinary medicine, we don't really cover really in-depth clinical aspects of human disease. We certainly talk about it in veterinary school, but it's not to the same level that would be useful in a clinical environment for a human patient. And that's fair. We're veterinarians, we're not physicians. So the 3 reasons there are challenges is really that veterinarians are more aware of risks because of ongoing contact with animals, right? It's typically pretty close to the forefront of our mind. Whereas physicians are more focused on managing the complexities of the individual disease process itself. And so they're thinking more of those common diseases they're having to interact with. Physicians may not also be aware that there are pets at home. A lot of physicians don't ask that question. I was pleasantly surprised, and I don't know if that's just the community I'm in, but a couple of years ago, I went to urgent care and I was having issues with a longstanding cough and breathing troubles. And the ER physician asked what I did for my job. And I mentioned I'm a veterinary faculty member at the vet school. And she actually asked, what contact do you have with what types of animals do you have contact with? And that's the first time that's ever been asked when I've gone in for a medical appointment. And I think it's certainly in the minority. I think that's a great spot where it's an easy, again, a low bar of how we can try and improve messaging and make people more aware of what the risks are. So what really is the role of the veterinarian in zoonotic disease? I think this is important for us to really understand, right? So one is obviously epidemiology and identifying the sources of an infectious agent, right? So, all of us have gone through veterinary school and had some evidence, some level of epidemiology, certainly not maybe as in depth as it could be. And then many of you on this call right now have had even much more additional training in epidemiology. Probably many of you much more than I have had. And so, we're really good at this, right? And so in case of dermatophytosis, we're great at trying to track down where that source is, identify what the reservoir may be, and try and cut that off, right? Figure out where that stemmed from. Situation-specific risk factors, right? So identifying, in certain scenarios we may be at a higher risk for brucellosis spilling over, and that may be a concern, and how that might be a concern at a raw milk dairy farm that's selling to customers under the table, right? Thinking about risk reduction strategies, we're pretty good at that as well. How do we try and reduce risk of salmonella spread? Keeping kids under 5 from buying a turtle, or at least telling their parents how to better wash their hands, informing people not to kiss their backyard poultry flock, right? Those are all risk reduction strategies. Managing the source from the animals, right? So understanding how we better utilize vaccinations to hopefully stop disease spread or at least minimize clinical signs, and how we use preventatives, to stop vector-borne pathogens, as an example. Advising immunocompromise. Well, certainly as veterinarians, we are not really given the ability to ask people directly if they are immunocompromised. That gets into the realm of being a physician and personal health information and HIPAA concerns. But we can bring general information when we talk to clients about, what are some risks that would be apparent if somebody in your household is immunocompromised, or somebody you work with or manage is immunocompromised. Making people aware of those is certainly an important role for us to play. And then obviously within our own practices and our own clinics, we have a huge role to play in infection control. And those are, as we'll talk about later, areas where we kind of fall down on as well, even though it's within our own realm of control in our own sphere, right? So the final two I want to bring up are kind of points that I want us to think about. And I've brought up in other venues before, but I think it's important to talk about here. One is, do we have a role in asking client their health status? I think we're a very trusted profession, and as we've all experienced, I'm sure, in interacting with clients or owners at various levels, large animal, small animal, whatever the case is, when you're in that exam room or you're out on the farm, clients tend to tell you things that you'd be surprised to hear about, right? That are oftentimes be quite personal. And we're taught that we should not be engaging in that and that we should refer those people to the physician. But is there room, setting aside liability, setting aside some of the other regulations in place, that we should have that dialogue about health status and be a better advocate for our clients and for the whole of the family approach. And then stepping it up a notch further, is there an actual formal role for us? Whether we can have a referral from a physician. Physicians aren't necessarily comfortable talking about zoonotic diseases. And could they actually refer a human patient to us to talk to them about zoonotic disease risks and concerns, or have us have a teleconsult with them, right? Could that be billed in some way, right? That we pull into this. And yes, this opens up a whole can of worms about liability concerns and malpractice concerns and where we would fit into the healthcare system. But I think it's something to think about, and something that I talk about a little bit later too, and it's actually been researched a little bit. And then beyond infectious disease, we have concern about trauma, and certainly trauma can go along with concerns about zoonotic diseases, like cat scratch fever or cat cytophagia from bites, all those sorts of things. But then trauma by itself is a risk factor that we need to try and help mitigate for our clients and owners, right? From animal bites and scratches in companion animal setting to being stepped on, or lots of other crushing injuries, things like that in a large animal setting. And we also know that physical abuse of animals is also an early indicator of potential domestic violence that can spill over into the rest of the family members as well. And so we have an obligation, obviously, to report that as well, and that's certainly a role that we should play. And it's always one of the top 10 topics discussed by veterinarians about animal bite prevention. And so I would be remiss if I didn't mention this in this. So occupational risk is also another big one too. We need to be aware, obviously, most of us are, when we talk about specific occupations, that we need to target specific zoonotic disease risks, right? And these are just some examples up here about, pig farmers and Streptococcus suis, or meat packers and Campylobacter, or Salmonella or E. coli, right? Streptobacillus milliformis, rat bite fever, for pet shop employees, right? These are all things that we should be advocating for. And many of us, interact with a PetSmart and try and consult with them about trying to get their animals better health care. Or we may be the point person for developing an occupational risk health plan for a large integrator or operation, right? And this may be a thing where we can help steer some of this guidance. And then there's been a lot of other factors that are coupled with increased risk. And an article referenced earlier by Stoll from the Canadian Medical Association journal in 2015 really tried to dive into some of these. And so certainly there are factors on the animal side, right? So what type of species is the animal patient, right? And what age is that animal patient? Those certainly can increase or decrease risk factors. The management of that animal, right? What are they housed appropriately? Are they being handled appropriately? How are they being socialized? Those can all impact, the trauma or infectious disease risks as well. And then client-patient factors, certainly the age of the owner or client, right? Are they less than 5 years of age? Certainly has a increased risk for getting a zoonotic disease. And if they're greater than 65 years of age, we know that they're immunocompetency starts to wane a little bit as well. And so there's certainly increased risk there. Certainly, as mentioned earlier, immunocompromised individuals, whether it's from an infectious disease or cancer or a wide number of things, are at increased risk. And then women who are pregnant, we all know that there are times during pregnancy where we certainly have a decrease in immunocompetency as well of that woman and the fetus that potentially set them up for risk. And these are all based on case control and cohort studies that have looked at these aspects and tried to find strong associations, whether it's odds ratio or relative risk or that sort of thing. And then the outcomes, because of these risk factors, we could have increased risk for zoonotic disease in these individuals. Some may have more severe disease or more severe complications, or symptoms may last longer. Right? So these are all things we need to keep in mind. So with that in mind, I want to ask another question for you. Have you ever contacted a physician regarding a patient concern? This is a yes or no. Still give you 20, 25 seconds here to answer this. So that's great. And I'm glad to see that 30% said yes. Usually when I ask this question, maybe 2 or 3 hands out of a group of 60 say yes. Obviously, we have a skewed sample here with who's attending this webinar right now, but it's great to see that at least a decent number of you have actually contacted a physician, which is fantastic. So I have a follow-up question now. Do you have an ongoing professional relationship with a physician in your community? Yes or no? That's great. The breakdown's almost exactly the same. I'm glad to see that. And hopefully that means that's why you reached out in the first place, is because you already had a relationship, or maybe it went the opposite direction. So I think that's fantastic. So I'm glad I'm going to be preaching at least to some of the choir here a little bit. But, I think we all talk about One Health and we talk about One Medicine, but we all know that it's really challenging to put into practice, right? Physicians diagnose and treat zoonosis that are uncomfortable discussing, and there's lots of studies out there that talk about that. Majority actually feel that veterinarians have more knowledge and understanding around zoonotic disease and readily admit that fact. And there are some that feel veterinarians should be brought in for cases. Veterinarians, as we talked about earlier, are comfortable discussing zoonosis, but majority have never contacted a physician, which is still true here in this setting. There's actually a great Australian survey that went out there that found that public as well as professionals in Australia support veterinary involvement in human cases. So the stats were something like 80% of the public would support having a referral from a physician to a veterinarian to discuss zoonotic disease risks or concerns. Obviously the veterinarian is not doing a physical exam on the human patient, but at least consulting with them and having that discussion. And that could actually be, and obviously Australia has a very different healthcare system than what we have here in the US. But that's interesting to me that that's such a strong support. And I think the numbers are in the low 70s, at least on the professional side of physicians willing to do the same thing. And I'm not saying Australia's mentality around healthcare or how they view veterinarians and physicians are the same as what we have here in the US. And I recognize that not everybody on this call necessarily is in the US. But I do think there are some great parallels there, and it's certainly encouraging. Patients in general do not view veterinarians as a source of information for human health, right? They go to the physician, and that makes sense, or the nurse practitioner, right? They're not going to necessarily go to a veterinarian for human health concerns. So there's this divide here. We need to figure out how we can get around that. So best practices and recommendations. Let's talk about what are our next steps. So one last question for you. How knowledgeable are you on which diseases to report to a public health agency in your state? I'm giving you 3 options here: very knowledgeable, somewhat knowledgeable, or not knowledgeable. And there's going to be no shame or shade thrown your way if you check not knowledgeable. Totally fair. And I think we're going to get a pretty robust response from this audience. Great. So as I expected, we have a large number, almost half, that are very knowledgeable, which is fantastic, and then still another half that are somewhat knowledgeable. So that's also good too. So we'll still talk about some of these aspects here moving forward. All right. So I'm sure most, if not all of you, have seen this setup before, right? This is the hierarchy of controls. And we think about where biological and infectious hazards fit into this, right? And this is around occupational health and controlling the workplace setting, and how do we address concerns there to minimize infection prevention. But it applies in a lot of settings, right? And we all know this. This is paralleling HACCP, the hazard access critical control points. And this is straight from the National Association of State Public Health Vets, Veterinary Precautions for Zoonotic Disease Prevention and Veterinary Personnel from 2015, right? This should be familiar to many of you, but I want to still throw it up here. There's lots of regulations and guidelines that do apply to veterinarians that relate to zoonotic disease. So OSHA does have guidance. So Personal Protective Equipment Standard is there, 3151, which talks about what PPE needs to be put in place. They also have the Respiratory Protection Standard, 1910, which also delves into what's time we need to pull in an N95 or when a surgical mask is appropriate or a face shield, those sorts of things. Certainly there's going to be some updating as COVID-19 has come through, but these were in place and have been in place for a while. California has a general industry safety order. And we all know California often has more refined or greater regulations than many other states or the federal regulations state. But I do find it interesting that in the general industry safety order for California, zoonotic disease is specifically called out. This specifically talks about the measures the employer will use to control employee exposure, including 10 different aspects, from engineering controls to procedures for safe handling of hazardous substances, procedures for application of gases like inhalational anesthesia, respiratory protection, PPE and protective clothing, decontamination, disposable animal waste, the contaminated PPE, the medical services, what training is required to be done, and even record keeping that should be enforced, right? So they've spelled a lot of this out, for better or for worse, in their guidance. And the NORA, the National Occupational Research Agenda, has brought in not just human healthcare professionals, but also veterinary healthcare professionals in this. And they're constantly trying to study better ways to mitigate occupational risk in a healthcare setting. So these are important for us to think about, right? As we work in settings, or we provide guidance or regulations or enforce guidance or regulations in various settings of veterinary medicine. So the recommendations from the American Association for Feline Practitioners basically spells out several of these guidance points. So veterinary staff should be familiar with zoonotic diseases and discuss those with owners as well. Teach all owners techniques to avoid being bitten or scratched. Communicate that willing to help if the owners have immune deficiency while being discreet. So one way is to do it indirectly by using signs or posters or pamphlets. So you don't actually have to talk or engage or get yourself in potential legal trouble, but just have that information available. Rabies vaccination being strongly recommended. And obviously in many jurisdictions it's required. External and internal parasite control is recommended. Again, this is the feline practitioners, right? But this applies in a lot of places. Provide information to owners on public health aspects of zoonosis, but we cannot diagnose, obviously. We need to document that in the medical record. So we know that we definitely discuss this with the owner and that it can be referred back to in case that comes back from legal reasons. But also, if the next practitioner comes along and needs to be able to know what was discussed, obviously that's important to document. If the patient has potential zoonosis, always recommend the owner go talk with a physician and volunteer to speak with the physician, which I think we can do more of. And then contacting the appropriate public health officials, right, if it's a reportable zoonotic disease. In Illinois, we have about 74 in the 70s, I can't remember the exact number, which is very shameful, reportable zoonotic diseases that we need to make our Illinois Department of Public Health aware of. And then we get back to breaking the chain of infection, right? We've all covered this in veterinary school. We've all covered it since then, right? Talking about how do we interrupt that susceptible, infected, recovered transmission cycle on the left, and then thinking about our hierarchy of controls again, right? And that the best measure is obviously eliminating or substitution of the hazard. And we always talk about, I think PPE gets a lot of focus, especially in the media, but I think everywhere really, because it seems like it's something tangible and individual can do. But it's, as we know, it's at the bottom of the hierarchy of controls, right? So eliminating or substitution of a hazard can be critical. So an example would be in a small animal clinic, for example, excluding wildlife so that you minimize that whole risk of potential diseases there and you don't see wildlife at all. Engineering controls. So again, going back to a small animal clinic or a lab animal setting or whatever, we have sinks for hand washing in every room, right? So there's no barrier or less of a barrier to washing your hands. Administrative controls is actually the hand washing requirement. So having a policy in place that says you need to wash your hands and this is what you should be doing. And then PPE, is providing enough personal protective equipment, obviously, to be appropriate for whatever procedures you have to do. So on the hand hygiene side here, it gets harped on a lot, but this really is the single most important measure to interrupt disease transmission. And if nothing else, this should be the thing that's harped on even more, in my opinion. Plain soap and mechanical friction is sufficient. Obviously, we know about the time component, about 20 seconds being the ideal amount, at least, that we do. Studies have looked at also the fomite control of how you work within a hand washing station too. So refillable soap dispensers should be empty before refilling. Otherwise, that can be a focal point where potential bacteria or other pathogens can hang out. Water temperature doesn't matter. It doesn't have to be hot or warm or cold. It's really about the mechanical friction in the soap. If you're using lotion in a clinic situation, especially if you're washing your hands a lot, have your own personal lotion. Don't use that communal large Jergens bottle of hand squeeze lotion, right? That can serve as another fomite where bacteria can hang out and contaminate everybody's hands. Disposable hand towels, although not environmentally friendly, are really the way to go. Again, trying to eliminate that risk. And hand rubs can be quite effective. They take a third of the time, but obviously we all know that you can't have biological material on your hands or it's not nearly as effective. So if that's not the case, if you're just coming from one exam room to another and you haven't been all over the animal, then certainly hand rubs with appropriate alcohol or ethanol in there can work great. And a lot of these this is hand hygiene. A lot of it kind of talks about small animal stuff, but there's been a lot of work looking at fairs as well. State fairs, county fairs, and how effective are we controlling disease risks there as public interacts with petting zoos or with fair animals, show animals, that sort of thing. And there's a great paper that actually just came out last year by Lauterbach in Preventive Veterinary Medicine that looked at 652 fairs across 7 years and found that 77% of animal interaction exhibits actually had hand wash stations, which is fantastic. But they did find in doing some observational studies at these places that only 7% of fairgoers actually utilize them, right? It's great to have it, and that's the first hurdle, but then getting to utilize them appropriately is the next hurdle. A lot of the hand washing stations did not have signage for proper hand washing technique, although there were signs saying that you should be using hand washing stations because of diseases. They didn't talk about how to properly use them. And then they went through some of these stations and actually did samples to find out what sort of potential antimicrobial resistant bugs in there, and found 75% of samples actually had AMR coliform bacteria in place. But certainly, it doesn't mean that's the end of the world, and that happens in a lot of places, but we need to be concerned about how are we actually implementing some of these control measures. On the PPE side, obviously each employee must know when it's necessary, what kind is necessary, how to properly don and doff, which is probably the biggest mistake individuals make around PPE, what the limitations are, and how we care for and dispose of that PPE, right? Gloves are the first line of defense that I think most places generally use, and that's great when you have contact with feces or bodily fluids, anything coming out of an orifice, right? Or non-intact skin. Specifically, if we're doing dental or obstetrics, or resuscitations or necropsies, we should definitely be donning gloves. And if we're cleaning cages or litter boxes or environmental surfaces, or even doing laundry, we should be having our staff and ourselves putting gloves on. It's a pretty simple preventive measure. Facial protections, if there's splashes or sprays likely, lancing abscesses, no matter how fun it is to try and dodge it as it comes at you, or flushing wounds, dentistry, obstetrics, or necropsies, we should probably be having facial protection, putting a face shield on, ideally, or goggles. Respiratory tract infections, if we're concerned about that, using respirators is great, but obviously we need to have them properly fit tested if we're going to have them be 100% effective with N95s. This is particularly true if we're concerned about Coxiella burnetii, brucella, or chlamydia. I apologize for my spelling of Coxiella up there. Certainly if we're doing power tools with necropsy, getting into the head or getting somewhere else. And then surgical masks, we all know, especially after COVID, designed to protect the patient and not necessarily the wearer, right? They can provide a little bit of a barrier, but it's not the goal. It's for water droplet transmission. And then PPE, protective outerwear. right? We all know what we should be wearing. Ideally, most of us are probably not wearing this, although I'm sure some of you do on a daily basis. We need to make sure we're wearing this when appropriate. So some other protective actions we can do within our clinic or practice setting is how do we do patient intake, right? How are patients and their owners or clients coming in? How do we channel that so that we make sure that there's a good flow, that there's not interactions with other patients, that people aren't potentially injured as they come in, and if that patient is potentially very sick or has a zoonotic disease, they can come in a different way potentially. How do we handle the animals and injury prevention, right? Are we doing safe cat handling practices, right? Are we using proper restraint devices if a dog is potentially going to bite? How are we handling this or mitigating stress, lowering lighting so that we can decrease stress, but not lowering lighting to increase injury, right? How do we examine those animals? Injection, venipuncture, and aspiration procedures. These are big spots where a lot of us get needle sticks. I readily admit I was in private practice for 4 years in small animal and certainly had my share of needle sticks. But we need to log those, right? And actually report those, document that, and review them so that every 6 months or every year, somebody in your practice is reviewing that log and deciding, is there a spot where we can change our techniques to minimize our exposure? Certainly high-risk procedures like dentistry, obstetrics, resuscitation, or necropsy, we should think about better PPE or protective actions. Diagnostic specimens, we think a lot about that lab that's right back there behind the exam rooms, and it happens to be right next to where you're keeping your water bottle to drink for the day, right? Is that the best spot to keep it while we're doing fecal floats? Probably not. And then wound care and abscesses is another high-risk spot as well. I'm going to mention these next 2 slides about environmental control. These should be pretty straightforward, right? General level of destruction of microorganisms. We know that detergents can be quite effective. It can remove up to 90% of material we want to get off of the surface just with a detergent. But then we need things like sanitizers or disinfectants to really get the next mile. And obviously, if we need sterilization, we need to autoclave or do something similar. And then contact time, something I harp on with my students all the time, especially if I'm a wildlife clinic. Thinking about how much contact time is needed is really important. So this is a study from 2010, looking at various compounds here on the x-axis and time in minutes on the y-axis. And in red, we have the drying time, and in blue, we have the disinfecting contact time, right? So you can see the drying time in many cases is less than the disinfecting contact time. So we need to keep that in mind that just because it's dry doesn't mean it's disinfected. From the occupational health side, employee vaccination policies, we should be, especially in small animal, but in a lot of scenarios, I would push for having rabies vaccination in place, pre-exposure vaccination in place, and then doing every 2-year titer checks. Employees should be tetanus vaccinated, obviously, too, and boosted appropriately. And we should really advocate to make sure that everybody gets seasonal influenza vaccines as well, too. We interact with clients all the time, and that's really important. And then documentation of exposure. There are OSHA forms that we have to comply with, 300 and 301, and then 300A for if you have more than 10 employees. That hopefully many of you who are practice owners or in practice are aware of and familiar with. And then having regular staff training, at least annual training on some of these issues. These don't have to be 2-hour-long or weekend-long getaways about training, but they need to be 10 or 15-minute refreshers, if nothing else. Or new employees get a little bit longer version, right? And then be aware of, if somebody's immunocompromised and they can disclose that to you, obviously that's to be kept protected, or if they're pregnant, right? We need to make sure we're trying to mitigate those risks. And then the last piece around your specific practice is really creating a written infection control plan is critical. As I mentioned, the National Association of State Public Health Vets, Veterinary Procedures of Zoonotic Infections, 2015 document is great. And part of that is that they add the Appendix 4, which is basically a Word document that you can populate in for a written infection control plan. So they've done a lot of the nitty gritty, so you don't have a blank paper syndrome here and you can fill that in. Make sure that it's flexible, but that it has explicit and well-organized guidance. There's contact info of who to reach out to within the practice, outside of the practice, and we'll talk about that in a second. And less than half of veterinary practices have an infection control plan. It's not rocket science, it's not super hard. And we know that studies have shown that those without one or more than 2 times is likely to happen. Relationships outside of your practice, and this is one of my big things, and I would advocate for those who are in practice and those who interact with practices to push for this more. So get a physician buddy. Obviously, quite a number of you do have one, which is fantastic, but I'd encourage more of you to get on board that train. I did a pilot study in 2018 in DC with a physician veterinarian shadow day, and I want to thank DC VMA as well as the licensing boards for both physicians and veterinarians in DC. They let me disseminate out an email, and we actually paired up physicians and veterinarians. We had 16 pairs, and they each spent a day at each other's office during the year. So there were 2 days basically taken up. One day for them, for the physician to go to the veterinarian, and one day for the veterinarian to go to the physician and spend time with them. And we provided some prompting questions and some disclosure forms they had to sign and things like that. And a lot of positive response. We actually had twice as many physicians volunteer than veterinarians to be part of this. And so there's definitely an interest there, and we can match up specialties. This can be something that can be organized at a local level or at a state level. The business card to the client, I think, is another fantastic opportunity. And I heard this in a talk several years ago, that you give your business card to your client, and then you give a second one to your client to say, hey, give this to your physician. And certainly a lot of them are not going to remember to do that, but some of them will. And that's just a great way to try and have that outreach point, right? And then in being involved in local groups, getting involved in community HIV/AIDS support groups, as an example. There's lots of different local groups to be involved in that you can be a resource for them to call on or have come to a meeting and give a quick talk about different things. Know your county public health department. I'm sure some of you harp on this as well, but many veterinarians don't know to turn to their county public health department, or don't know even that they have a county public health department. They can be a great resource. And certainly a lot of them are not a great resource because they are so understaffed or underfunded. But then on the flip side, you can be a great resource to them as well. And it's a great partnership to have in place. They're really the implementers for public health within the state, is at the county level in most states. And I put the link up here too, that HO provides a great link of those county public health offices if someone wants to know where they are. And then know your state public health veterinarian. I'm sure some of you on this call are state public health veterinarians. But this is a great spot too. Go to NASPHV's site and look up your state public health veterinarian. Almost every state has one, or somebody acting in that role. And so this is a great person to turn to with any zoonotic disease questions or concerns. So these are my final take-home messages. There are dozens of zoonotic diseases, right, that we talked about, but the risk from healthy animals is low, and going to healthy people is quite low too. But it's not zero. So we need to make sure that there's key steps put in place for interrupting the disease transmission, and that a written infection control plan is needed in every practice. And that's one of the things I'm going to stand by and keep advocating for. And then finally, your health and the public's health are always the most important. I know we're veterinarians, but part of our oath is protecting public health, and our own species still trumps any other species, and we need to keep that in mind as well. So that included some final resources here. As I mentioned, NASPHV is a great site, lots of great compendiums and information there. AAFP has actually got a great guidance on zoonosis. Obviously, I cited some of that. CDC's Healthy Pet site, I think, is quite well developed and a great resource. Companion Animal Parasite Council is another good source. WASAVA has a One Health committee that are continuing trying to develop some more documents and guidance. And then Bayer has a companion vector-borne diseases site. And then the European counterparts looking at companion animal parasites. It's a great spot too. So with that, 50 minutes in, and any questions that I can answer. I know there's a few in the Q&A.
There are a few questions, Dr. Sanders. Your presentation was very good, very well received, and generated a few questions. All right, the first question is, would you not also consider vesicular stomatitis of horses, cattle, sheep, and pigs as a zoonotic disease?
I would, yes, I would.
Okay. Another question is if you're aware of any toxoplasmosis exposure studies in veterinarians. The individual submitting this question became aware of his own active infection in 2019.
Yes, I feel like I'm not familiar off the top of my head, to be honest, but I feel like I have read at least one or two serosurveillance studies looking at that, but I cannot pull that off the top of my head. I'm happy to follow up if you wanted to send me an email, and obviously it's up on the screen.
Okay. This question, a little bit more broad. What experiences have you had that are or were the most meaningful in terms of improving your ability to improve response to zoonotic disease risks?
Yes, I think my most meaningful experience is that physician veterinarian shadow day. I was really encouraged by the positive response to that, and that there's this encourage that both physicians and veterinarians are interested in trying to get to know each other better and understand better what each of them do on a day-to-day basis. So I think that's one of the biggest hurdles is there's I think we all have a sense of what a physician does, and physicians sometimes have a sense of what a veterinarian does, but it's not really hard and fast. And I think that's one of the big spots where if we can improve that communication, that's going to go a long way for improving the overall family health, in my opinion. And so that's been my most rewarding experience to date.
Towards the end of your presentation, you talked about having a relationship or contact information for a state public health veterinarian. Are all states required to have a state public health vet? And I'd also throw in, are you aware of any states that do not have one?
So yes, so not every state's required to have a state public health vet. It's really, my understanding is, and somebody can correct me if I'm wrong. So it's really up to the state deciding that. So there's no federal mandate that says every state needs a state public health veterinarian. Most states have opted to have a state public health veterinarian, or potentially a state epidemiologist who is frequently a veterinarian and kind of serves that role. Some states have also opted to provide different funding mechanisms to bring in somebody who's actually a CDC employee, as an example, and act as a state public health veterinarian. So there's various funding mechanisms that states have opted for to fill that role. I couldn't name specifically off the top of my head which states do or do not have a state public health veterinarian. I can name a couple that have CDC employees acting in that role. So again, a majority of states are going to have a state public health veterinarian that's paid, that's a state employee. But there are a few, I'd say probably less than 10 that do not.
We had one of our attendees that just provided a list of state public health veterinarians. I just shared that link in the chat feature. Is there a resource or example of an infection control plan for veterinary facilities readily available somewhere on the internet?
Yeah, so that's what I was referring to with the National Association of State Public Health Vets site with their veterinary compendium on zoonotic diseases. So if you go to that same link and that was shared by Dr. Toring, and just go to just the nasphv.org, you can find that compendium for zoonotic diseases. And in there, the Annex 4 is the example template that I mentioned in the presentation. So that's a great starting point, in my opinion.
Any recommendations on how you would discuss tick control with clients who cannot afford flea and tick control? And that would be for both large and small animals.
Yeah, I think that's a great question about affordability and financial ability to pay for this, whether it's on the small animal side or large animal side. I think it's really trying to think about what are the biggest disease risk concerns in that area. So knowing, is Rocky Mountain spotted fever a big risk, or is Lyme disease a big risk, or is anaplasmosis a big risk? Like, what are your biggest concerns, and what do you want to control for vectors? And then working with the client or the owner to think about creative ways to address that. So obviously there are generic products for many of these things, and so thinking about, if they can't afford doing it year round, which is obviously the recommendation in most places in the country, certainly for companion animals, can you target a specific active time of year that might be a better use of their resources, right? So I think trying to find a way that meets them in the middle to recognize that there is a restriction, but still get the animal some protection.
We're at an hour, and I do have one more that if you had any comments on the CDC's recent restriction of importation of dogs from over 100 countries, considering the rabies risk.
I can make a comment. I don't know that it's my opinion, but I think this is, in my opinion, a step in the right direction. I don't know that it's necessarily been messaged off the right way. So I hear your point about best practices for communicating that. Dog importation, cat importation has not had the strictest regulations in place. And so I do think there needs to be some improvements. And one of those is certainly a concern about how well vaccinated those animals are before coming to this country. So that I support being more critical of that. I'm not sure that it's been carried out in the best manner. So as far as best practice of communication, I would comment that letting those clients or owners know that this is the reason why that we historically have not been great about monitoring rabies coming into the country, and that we want to make sure that we're in a better spot to ensure that animals are healthy when they come here, and minimizing that potential infectious disease risk. Not an easy conversation, especially if somebody wants to move back to the US and bring their animal with them. So I can appreciate the concern there.
Wonderful. Dr. Tomasi, did you have any final comments from the Continuing Education Committee?
Just that we are always looking for somebody interested in presenting. So if you've got a topic you would like to hear, or you have a presentation that you would like to give, please let me know, and we can see if we can fit you in. We still have about 4 months left in this year where we're still looking for topics and or speakers.
So with that, I will close this session. Again, thank you, Dr. Sander, a wonderful presentation. And please, everybody, watch for your emails. We are getting ready to schedule our July CE webinar very shortly. So everyone have a good evening, and thank you very much for attending.